Susan, do you know if Tom Walsh has joined yet?
I was just going to let you know right before you came on, he's having some issues with Teams. So he is trying to get on.
Great. All right, we'll
Don't
give
see
it a
him
minute.
yet.
All right, thanks.
So Kristen is working with trying to get Tom onto the call, Chair Foster. So she just emailed him a link.
Okay, we'll give it a couple minutes. No big deal.
Sure.
Can you hear me okay, Susan?
Yes. Welcome, Board Member Walsh.
Okay, a little after 1, so I'll call to order the Green Mountain Care Board's hearing of April 5th, 2023. Today we have a number of agenda items. First, we're going to hear from Christine Smith and Laura Beliveau. Ms. Smith is with MVP Healthcare, and there's a potential vote relating to MVP's non-standard QHP plan review and potential approval. Then we have a roundtable discussion. We have Zach Cooper, who's a professor at Yale University and a director of health policy at Yale's Institution for Social and Policy Studies. And then General Counsel of the Green Mountain Care Board, Mike Barber, will present potential revisions to the Certificate of Need monetary thresholds. And with that, I'll turn it to our Executive Director, Ms. Susan Barrett.
Thank you, Chair Foster. We do have a new public comment period that is on the One Care Vermont's revised budget submission. We received that on March 31st, and we're accepting public comments on that until April 28th and have a hearing on, we'll have a meeting on that starting on April 3rd. Probably have several meetings on that. Or sorry, May 3rd. When I start throwing out dates, it's dangerous. The other public comment is ongoing, as I've mentioned previously. We are accepting any public comments regarding a next potential all-payer model. We share all of those comments with the Agency of Human Services and the Governor's Office as they are leading the negotiations on the next potential model and the current implementation of the current model. I also just wanted to alert the public and others that we did post our schedule for April earlier this week, and We have several, we will continue with some roundtable discussions, and also we're going to have a primary care sustainability roundtable discussion on April 19th. Also in that that same day, we have a primary care advisory group. So that will be our all things primary care day. And please just take a look at that schedule. If you have any questions, reach out to Kristen or me. And then in closing, I just wanted to thank Brattleboro Retreat for hosting Dr. Merman and I this morning. We had a really informative conversation with Linda Rossi, their CEO, and heard about the incredible things that they're doing down at the retreat. And as the CEO, Linda, said, it's not her, it's the workers at that hospital and the staff who are doing the incredible things every day. So I just wanted to have a shout out to Brattleboro Retreat, and had a really informative discussion with them this morning. And with that, I will turn it back to you, Chair Foster.
Thank you. I'll turn to our minutes from March 29th, 2023, last Wednesday, when we reviewed the hospital actuals and hospital budget guidance. Is there a motion to approve the minutes from March 29th?
I'll move approval.
Second.
Is there any board discussion? Hearing none, is those in favor of approval of the minutes from March 29th, please say aye.
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 Aye. And the vote is unanimous and the minutes are approved. And with that, I'll turn it to Laura Beliveau, who is a staff attorney here at the Care Board, and she can introduce Miss Christine Smith from MVP. Laura?
Yes, good afternoon. Today, Christine Smith from MVP Healthcare will be presenting MVP's proposed changes to the rate designs for 3 non-standard plans. In accordance with the board's established process for non-standard qualified health plan proposal review, earlier this year, MVP notified DVA and DFR of proposed changes to its non-standard plan designs. DFR determined that changes to the 3 plans being discussed today contain what are called significant changes requiring board review. The board has established criteria to approve proposals for new plan designs and significant changes to existing plan designs that add value to the Vermont marketplace. A vote has been noticed for this matter. And with that, I introduce Christine Smith, Product Manager, Commercial Product and Strategy and Design at MVP Healthcare.
Thank you, Laura. So let me share my screen. So as Laura mentioned, today I'm going to be speaking about our proposed 2024 non-standard qualified health plan designs and some changes that we have. I'm going to give you an overview and give you a little bit of information about what's going on with our members and our market and why we're proposing these changes, give you an outline of the plan designs, and then open it up for any comments or questions. So with an overview, this is our non-standard plan design portfolio that we have today and what our membership was in these plans as of February 2023. MVP is going to continue to offer all standard plans and the catastrophic plan, as well as 2 non-standard high deductible plans, 4 non-standard non-high deductible plans, and our 2 reflective plans, one of which is an HDHP. In the non-standard portfolio, that is. So what triggered the Green Mountain Care Board review? As Laura mentioned, DFR determined that we do have 3 non-standard plans with what they're considering significant changes. That would be our Silver 1 and our Silver 1 CSR 73 and our Bronze 5. The plan designs for these 3 plans are almost identical to the previous offering, but due to the amount of increases in deductible and out-of-pocket max, it triggered this review. I'm not going to read through the evaluation criteria, but our plans do fall into item 1, where there's a substantial difference in the deductible out-of-pocket max or the RX deductible. We continue to offer plans, we want to continue to offer plans that add value to the Vermont market. The proposed changes to the deductible and out-of-pocket max of the Bronze 5 would decrease the premium of this plan by an additional 1 to 2% based on the 2023 plan designs. We're not going to comment at this time on what the market changes are going to do to impact our premiums yet. But the changes to the silver plans were mostly due to AVC calculations, in that they were falling out of metal level if we didn't make some changes. So, and I will go through that as we progress. So just to give you a little bit of information on our Bronze 5 membership, in 2021, when we look at what we had as a deductible in 2022, which was $78.50, only 6.94% of our members were hitting that deductible, so 93% did not. In 2022, the deductible was still $78.50 and 6.95. So we're hovering right around that 7% mark on members hitting their deductible in this plan. So our proposed plan design is to move the deductible from what it is currently today in 2023 of $9,100, because we made a significant change last year as well, up to the maximum $9,450 for this year, in order for us to continue to offer the most cost-efficient plan possible. In 2023, showing our membership numbers, this plan did hold steady, showing that members were not out there shopping for a cheaper or different plan. We've kind of come to the conclusion at MVP that the members in this plan are not in it because of the deductible or out-of-pocket max. These are most likely members that they're healthy, they don't use their benefits that often, and they want to have health insurance to keep themselves covered, but they're looking for something with a low premium. The impact to the Bronze members in this scenario is a low premium, which makes the plan attractive to them. Is there any questions so far? Okay. So what are we hearing in Vermont? Our sales team is telling us that groups are leaving for level funded plans because the premiums are increasing at such a rapid rate. We have some comments from some actual Bronze members that have mentioned that the premiums are exorbitantly expensive, and if my employer didn't cover 80%, there's no way I could afford a monthly premium. And then we also did a survey, a sample size of 342 to health benefit administrators, in which 31% of the health benefit administrators deemed price as the most important factor in choosing a health plan. So that kind of backs up what our theory has been and where we base this theory off of. So our product portfolio for 2024. The first plan would be this Vermont non-standard Silver 1 plan. And the first column will show you what the plan is at today, which our deductible is $2,100 and our out-of-pocket max is $7,000. Leaving that as is, the plan did fall out of metal level in the AVC calculator. We currently have 582 members in this plan as of March 2023. We're proposing to move the deductible to $2,500 and the out-of-pocket max at $7,500, and leaving the other cost shares alone. The only other thing that we were doing was moving the RX out-of-pocket max up to $1,500, which is standard amongst all of our plans today. The next plan with a change would be the Silver 173, again for the same reason, as it fell out of metal level where it is at $1,500 and $6,150. So proposing to move this to $1,750 and $6,500. We have 355 members in this plan today. And again, moving that RX out-of-pocket max to be consistent with the base plan at $1,500. And lastly, our Bronze 5, which we brought in front of the board last year, where we moved the deductible up to $9,100 last year. We maintained our membership in this plan. We have 672 as of March 2023, and we're proposing to move it to the max of $9,450 for both matching deductible and out-of-pocket max. Again, not touching any of the cost shares. Okay, so that was the portfolio. I'm going to stop sharing so I can see you. And if you have any questions, I'd be happy to answer them. I also have Chris Pontiff on the line with me. He's our MVP actuarial. So if there's any questions for him, he'd be happy to answer them as well.
Great, thank you very much, Ms. Smith. I'll turn to board questions and comments. Then I'll turn to the healthcare advocate and then the public. Ms. Beliveau, do you by chance, can you publish the potential motion language? Would that be possible? Or I would like folks to see it if we can. I can just say what the motion language is if that's easier for you. I think you're muted.
I am. I do have a slide and happy to share that. So that is the criteria, and if I can find a little button, that is the suggested motion language.
Actually, I'm sorry, Ms. Beliveau, before I turn it to the board, did you have any additional comment or anything you wanted to add?
I didn't have anything specific to add, although I will note that DFR is the one that evaluates whether the non-standard plans require board review, and DFR didn't have any objections to these proposed changes to MVP's rate design.
Great. Okay. And with that, I'll turn it to the board members for any questions or comments.
I had a quick question, but I'm not sure if others are wanting to go ahead.
Go ahead, Jess, if you'd like.
Okay. Is it possible to flip back to the MVP slides? I think it'll be the second to the last slide.
Sure.
It was the bronze plan. Yeah, I just a little bit of clarity. When I look down the second column and I see 0% all the way down, and then I see in the third column significant changes to me.
Yep.
So when you had said there's no changes in cost sharing, that strikes me as large
Yep.
changes in cost sharing.
You're absolutely right, and that is a typo, and I will fix it. They did not change. They did 0% because you can't have anything after the deductible. You'd hit your out-of-pocket max. So yes, you're correct. So the base of this plan is that once you hit your deductible, everything is 0%. The two caveats are that PCPs, there are 3 visits in front of the deductible, and tier 1 drugs are in front of the deductible. So I will fix that, and I do apologize.
Okay, thank you.
Thank you for
And then
calling
just
that
my
out.
second question is, when you were looking at the 2021 and 2022, suggesting that 7% of members hit the deductible when the deductible was $7,850.
Yes.
We're in 2023 now, and I recognize we're still in that year, but there was a significant jump this year to 9,100, and I'm wondering if you have any preliminary data or analysis that might indicate what percentage of members are likely to hit the 9,100 this year. How significantly different is that from the 7% when the deductible was lower in previous years?
That's a good question. I don't have that information. I know Chris is on the line. We did not have it to pull for this meeting. But if they weren't hitting the 7,850, the percentage is going to go down significantly to even get to the average deductible that members are hitting in those bronze plans is around $3,500. So even less. Go ahead.
Yeah, and I can add a little color. It will be lower, certainly, right? Like the deductible's higher, the amount of people hitting it are going to be lower, but it's probably not going to be massively lower because the way that the claims are distributed is there's not a lot of people who are utilizing between 75 or 7,800 and the 9,100. It's if you hit the 7,800, you're likely to be above 15,000 type of thing. So it will be a reduction in people, but it probably will not be a massive reduction in people.
Right, that makes sense. And you had suggested that if you had applied this higher deductible, if I understood you correctly, to this year's premium, it would have been 1 to 2% lower, but you're not anticipating what it would be for 2024. Is that what I heard you to say? Heard Christine to say?
Yes. 'Cause
Okay.
We don't know
So
what
the
market-
hope is that this will be a reduced premiums.
Yeah, if we were,
with this
if we were
higher
to
deductible.
base it, if we were to base it on the plan year 2023, it would fall in the 1 to 2% less. But because we don't know what the market conditions are going to do to the rates, we still know it's going to be our lowest cost plan, no matter what.
Okay. Thank you so much.
You're welcome. Thanks for asking.
Any other board members with questions or comments?
Jess asked all of my questions, so I'm good.
I just have a brief comment, and I don't quite know how to. I guess my comment is that I know that high deductible plans offer significant benefit to people to be able to afford an insurance plan, and that many people wouldn't be able to afford any plan without the high deductible plans. I just always have concern of which this is not probably the right venue to necessarily deal with this concern that it does lead to a significant, or probably very small portion of people delaying healthcare. So I think it's a challenge to think through these plans and our concepts of rational choice in purchasing these plans. So just something I just want to comment. Whenever I see these high deductible plans, I think about the impact on people delaying care, but I also understand that the lower premiums really allow a lot of people to afford insurance at times for possible catastrophic events. So I think it's a complicated balance with these plans, and we do discuss this often, and I think it's important to express that. So, but thank you for the presentation.
Yes, if I could just comment on that, I just wanted to let you know that we do feel the same way, and we do have this discussion internally often. The reason why this plan is actually not a qualified high deductible plan is because we do give 3 visits at zero cost share before the deductible, as well as the tier 1 drugs, hoping for that exact thing that you just said, that people are not going to skip their care because we are allowing them to have 3 covered in full visits. Or no deductible visits, as well as no deductible on that tier 1 drug.
Thanks for that.
Yeah, thanks, Christine, and I thank Christopher for coming in and presenting to us today. The people purchasing the bronze plan you described as, did I hear it right, the most price sensitive?
Yes.
Generally, yeah.
Yes.
And you mentioned the average use of the deductible was $3,500. Do you happen to know the median? That average would be pulled way down by the zeros, right?
Yes. Yep. That's correct. I mean, I can tell you that in across our entire block, so not just bronze, the non-utilizers are somewhere in the, it bounces around year to year, but 10-15%. I mean, there's a high portion of people who are utilizing nothing. In bronze, I would expect that number to be significantly higher than, say, platinum, right? People are buying platinums generally because they need it. And so, yes, you're right. The median would be that's healthcare claim cost distribution, right? It's log normally distributed, and the median is always significantly below the mean. Yes.
Yeah. Or the other way around, the median would be higher, right?
For claim cost, yes. For, I guess, for amount of deductible used, right? That would go that direction.
Okay. And the deductible going to 9,450. What are the premiums for that?
Christine, do you know the current premium of that plan?
I do. The current premium for the Bronze 5 for a small group is $580 a month. And for individuals, $679.
Okay. So 580 times 12, 7,000, 8,000. So it's like $15,000 of exposure before insurance would really kick in, other than the 3 visits.
That's correct.
Yeah. I think it's, I wanted to ask to make sure that, because I think there's still a lot of people who may not, they don't see that full number because they, you know, the max out of pocket, we tend to think would include premium because that's coming out of pocket, but it doesn't. And so those need to be added together. And I think it's important to keep that in mind. And I know Christine and Christopher, you guys know it, but I think it's important to keep in mind because we really have an affordability crisis. The people who are most price sensitive, right, are facing an exposure of $15,000 a year. They get sick and need that in November. It resets in January. Right? So it's a crisis, and I appreciate you coming in and talking with us about it. But it's a tough situation for the folks that need to make the decision for the Bronze 5. So thanks again for coming in. I don't have anything else.
Great, thank you. Ms. Belvo, do you mind just publishing the, just so people have it in case they want to comment on the motion language? With that, I'll turn it to the healthcare advocate for any questions or comments they may have.
Sure, I just have a question and one comment. So Christine, I'm sorry to do this. We just put up this slide. Laura, Christine, could you go back to your tables? I'm so sorry.
No, that's my fault, Eric. I'm sorry.
Sure, no worries. Okay.
So I'm just trying to understand all the numbers that we've thrown out. So the 9450, so the deductible or the MOOP, is that for an individual plan?
Our individual and our small group plans. Oh,
so like, would the deductible be higher for a couple, twice that for a couple, and some larger amount for a family?
No, that's the deductible. Yeah, that's the maximum deductible and out-of-pocket max.
Regardless of the plan size?
Yes. So it's $19,450 for an individual on the plan and $18,900 for the family. Yes, you're correct.
Okay. So it's actually the total exposure. I'm just trying for a non-single person, a family unit, the total exposure to deductibles is higher than what we've been talking about. You know, and I think obviously others have spoken to the affordability crisis, and that's, you know, I know us and the board and MVP is all aware of that, so I won't harp on that. I think it's not before the board right now, but I think it's worth thinking about how other states have approached the existence of non-silver plans. So I would look at California and this dealing with this issue of potential consumer confusion and the various policy arguments around that. And perhaps that's a legislative, more of a legislative issue, but it is something that I think as a state, we should grapple with when we're thinking about how we want to make offerings to consumers. And perhaps in all instances, the most choice is not always the best option. And that's it, Chair Foster. Thank you so much.
Thank you very much. With that, we'll turn to public comment via the raise your hand function. Walter, good afternoon. How you doing?
Hey, Owen, how are you?
I'm okay.
Sitting here at my weekly dose of the Green Mountain Care Board. Tom pretty much took the questions that I had burning in my mind. So thanks to Tom for that. Jess and Dave also touched on what I was going to ask. I just wanted to say that we talk about deductibles and these heavy premiums of 600 and something a month. Most Vermonters don't even earn that per week. Then you get the taxes taken out of the paychecks. So most of them, you're living paycheck to paycheck, and that the purpose of the deductibles is to prevent people from using health care. So they're going to do a good job. I work out on the line in the tourist business, and I can tell you stories that the MVP sales forces would never, ever hear. I'll zip up now.
Thank you. Thank you for your comment, Walter, as always. Any other public comment? Okay, great. I'll move to approve the proposed changes to MVP's rate design for the three plans we discussed today. The Vermont non-standard Silver 1, the Vermont non-standard Silver 1 CSR 73, and the Vermont non-standard Bronze 5 plans as presented here today under the column labeled 2024 proposed that Christine had on slides 12, 13, and 14, respectively.
I'll second.
Is there any board discussion? All those in favor, please say aye.
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 Aye. And the motion carries unanimously, and the proposed changes are approved. Ms. Smith, thank you for coming in for your presentation. It's helpful. Nice to see you today.
Thank you for having me again.
Of course.
Have a great rest of your day.
Thank you. You too.
Thank you. You
Bye.
too.
Next, we have Zach Cooper, who's presenting. I'm not sure if Mr. Cooper is here yet. Is he coming on at 1:50? Is that right?
That's correct, Chair Foster. This is Susan. I believe it's 1:50.
Should we take a break till 1:50, or is that the best course here? Okay, let's do that. So we were too efficient today, which is not something that we often have as an issue, but today we're too quick. So we will take a break. We'll go to recess till 1:50, and then we'll resume with Mr. Cooper. Thank you.
report on outreach. Not only is it not
Good afternoon, Zach. We're all just coming back from a quick recess. We moved through our first topic faster than expected, something that's unusual for us. But
Good.
can
you guys hear me?
Back in just a moment. So here we
Okay,
go.
good.
Okay, it looks like we have 5 board members and Professor Cooper. So I'll take the meeting out of recess. And Mr. Cooper, Professor Cooper, thank you very much for being here. I hear you're a Vermont native, so everything you say will have great resonance with all of us. We love Vermonters here. I'm going to turn it to Tom Walsh to introduce Professor Cooper and give an overview.
Thank you, Chair Foster. And yes, thanks for joining us, Professor Cooper. Born and raised in Vermont, hailing from Brattleboro.
I will say not born. I will raise
okay.
for sure, but I will give up the born part.
Formative years.
Indeed, exactly.
Well, thanks so much for joining us. And just to give folks to set some context for today, a couple of weeks ago we had Jeff Stensland from MedPAC join us, and he talked to us about his research that really kind of fundamentally changed our understanding of what has been thought of as a cost shift. And that helped us all better understand how price and market concentration really affect cost. So the causation goes the opposite of what we'd previously expected. And I think some of your work on delving into market concentration has been also very useful. It's helped us, it's confirmed and expanded it on Jeff's work. And your work, having all payers and all hospitals involved in your research, has really fundamentally changed our understanding of findings from the Dartmouth Atlas, which was Medicare only, and not every hospital. And so the findings from the Atlas, thanks to your work, we now understand that those don't generalize to all hospitals and all payers. In fact, there's quite different. And so I'm really thrilled that you're here to share with us your research today and the implications from that. I'm looking forward to the conversation.
Terrific. Well, thanks everybody for having me. I'm just getting, I haven't used Teams on this computer, so I'm just setting it up. Teams may not be able to record. Okay, that's fine. So let's see if I can share and then we'll get going. So I'm delighted to be with you, and partly because I'm spent a bunch of time in Vermont. My parents lived in Bennington for 15 years, and also because I think you guys are trying to solve a really, really hard problem. And I want this to be much less like me sort of talking to you and much more like us having a conversation about what we do. And I'm going to walk you through, let's see here. Can I share my screen? All right, I can. So let me do Windows. This is like the ultimate professor sin, is not being able to share one's slides. All I do is share my screen, and so if I can't do it, I'm in trouble. Can you guys see the slides that are up there?
Yes, we can.
Okay, terrific. So what I want to do is, in a sense, give a tour of health spending in the privately insured and think about what's causing health spending in the privately insured to vary, what's causing it to grow, and that'll lead us to this discussion about the role of providers' prices. And so what I want to do is think about why providers' prices matter to us, why they should, why they vary, and why they're growing over time. And I think I'll speak for sort of probably about 30 minutes. And then we can sort of go from there and say, well, what do we do? And what options does that leave on the table for us as policymakers trying to think about how to make a health system run as efficiently and fairly as we can. I am an academic, I'm an economist, which means I want you guys to interrupt. I'm actually not comfortable unless you're interrupting. So please don't hesitate to I see Jessica, she's nodding. She's like, yep, I know the economic stuff, but yeah, please just interrupt, ask questions, and let's have this feel like a conversation. So I wanted to just level set in two ways. One is just sort of how premiums in Vermont compare to premiums in other New England states and also the US, and also just sort of anchoring premiums as a whole. So nationwide last year, the average premiums for a family of four were about $21,000. Most New England states are going to be above average. I think you're roughly in line with where New Hampshire and Maine and Connecticut are located. The reason I put these dollar values here is I think it's tremendously important to take a step back and just realize how incredibly high $23,000 are for premiums in the context, say, of buying a new car. And I give this talk every year, and this fact remains true every year, right? For the price we pay for insurance for a family of four, you can buy a pretty nice new car. And different states are toying around with mandates for insurance. And so we're mandating a whole lot of families in states with mandates buy a new car's worth of health insurance every year. And I think if you had an honest conversation with most families, that's not necessarily where they want most of their money going. Now, I think they're grateful when they get sick and they can afford it. But that's just, it's just an awesome sum of money and a number we can't forget. The other is, in spite of paying more than a Toyota Corolla for health insurance for a family each year, if we go to the far right of this, about 44% of folks with insurance coverage, right? So there's folks who have coverage, who've done the right thing, are worried about their ability to pay medical bills. And so it's not just that we have I think 15 or so years ago, we really talked about quality, access, and costs. And I think the Affordable Care Act did a remarkably good job on the access front. Broadly a 50% reduction in the share of the population who doesn't have insurance. The remaining tranche are folks, I think, split between groups that are really, really hard to reach, and then groups who are, in some ways, not making a crazy decision not to have health insurance. So often they're folks who are young. And what we sort of transitioned to is a little bit away from these access problems to cost problems, and cost problems that often manifest, ironically, in access problems. Right? So these are folks who are afraid to literally touch the healthcare system out of fear of a bill that can be financially devastating. It's folks who touch the health system unexpectedly and then get financially devastated by the experience, all while navigating all of the vicissitudes that go along with being in ill health. And I think this, for me, really illustrates it. So this is a survey by the Kaiser Family Foundation and the Peterson Foundation, which is looking at liquid assets for single-person households, multi-person households, and all households, and comparing that to the max out-of-pocket limits on the average employer-sponsored plan. And what you basically see, and these, by the way, are calling these liquid assets is being very, very generous, right? This is money market accounts, checking accounts, savings. This is non-mutual investments. This is your stocks. We actually asked the Federal Reserve. Their guess is that basically the average family has less than $500 in pure liquidity at any given point in time. And we've got family plans that have out-of-pocket maximums of $16,000. And what this means is that a real illness can be financially devastating for an incredibly large share of the population. Right? And I think this is fundamentally why we see 44% of the public with insurance very, very worried about the costs of healthcare. This for me is incredibly sobering. I show this to my students in the very first class of our class in health economics and healthcare policy. And it's showing that broadly a quarter of individuals with employer-sponsored health insurance are cutting off on buying food, clothing, and household items to pay for medical bills. Right? And again, this is the transition for me from this sort of access question to cost question. Right? We've gotten that taken care of. We've gotten people coverage. This is the consequence of what happens when you don't get costs under control. Right? That you're seeing a quarter forego food, you're seeing 14% taking on a second job. So why does spending, what drives health spending for the privately insured? So this is work from a project I did with John Skinner, who's at Dartmouth, Chima Dumile, who's my colleague at Yale, and some amazing students looking at the correlation in spending across Medicare, Medicaid, and the privately insured. And it's actually building on some of the work that Tom did. So let's take a step back. Up until about 2014, almost everything we know about healthcare spending, we know from the analysis of Medicare fee-for-service data. And Medicare pays providers using regulated payments that are set by the Centers for Medicare and Medicaid Services. Juxtapose that with what happens for the privately insured. So the privately insured are going to pay providers using payments that are set by a bilateral negotiation. And so broadly, every year hospitals, as you know, and insurers are going to sit down, they're going to start hammer out negotiations over prices. Medicaid is going to be some rough combination of the two. And what we found in that work was basically Medicare, looking at Medicare spending variation doesn't tell you anything about what the world looks like for the privately insured. And you can sort of see this comparing panel A on the left and the MET of Medicare in the middle, right? The correlation between the two is 0.02%, which basically means they're wholly uncorrelated. Medicaid is a little more highly correlated, both with Medicare and private spending, but not by much. So what leads spending to vary? So for an economist, spending's pretty simple, right? It's the product of prices times quantities. And what do we mean by quantities here? So quantity is the mix of services that get offered. So different places might offer sort of higher or lower acuity services. It's going to have a second dimension, which is the sort of number of things that get offered. You know, maybe one place only does an X-ray before they see me, and another place does one before they see me and 6 weeks after. And the third, which I think is important to talk about, that's in some ways under discussed, is quality, right? That's sort of an aspect of quality, a quantity that we sort of have to think of, sort of the type of service that we offer. And it's that times the prices of those services. And so I sort of think about that, like what drives spending. It's kind of like what influences what I spend on my groceries. It's the mix of things I put in my cart, right? Is it frozen or is it from the fresh aisle? Is it bananas? Is it blueberries? And then just the sheer sort of amount of stuff I buy. For the Medicare population, and mostly for Medicaid, it's quantities that drive spending variation, right? And that's sort of unsurprising because the price component is basically regulated. On the private side, what we've seen from some of my work is that it's basically 50% prices and 50% quantities, right? And that's because you have this extraordinary variation in private prices because they're not regulated. It comes down to market determined rates. And when we first did this, there were a couple of really surprising facts that came out, which I think are important for us to internalize. So the first was health spending on the privately insured varies by about a factor of 3 across the US. But it turns out that a lot of the places I was sort of thinking were going to be high spending in advance turned out actually not to be that high spending, and places that I thought were going to be inexpensive turned out to not be inexpensive. And so one really good example is Grand Junction, Colorado. So Grand Junction, Colorado had been sort of touted based on Medicare data as the model for the country. There was a famous New Yorker article by Atul Gawande that named McAllen, Texas. So everybody sort of knew McAllen is bad, but what they often didn't pay attention to in this article is he said, look, the opposite of McAllen is Grand Junction, Colorado. And what's really, really important is that when you look at the privately insured, McAllen is actually below average spending. And Grand Junction is, I think, the third highest of the 304, 306 hospital referral regions in the country. Right, and so it just sort of illustrates this picture of a lot of the places that we thought were low spending turn out to be very, very high spending. And a lot of the places we thought of high spending on Medicare turn out to be not that expensive for privately insured. Why is that the case? Right, it's basically because if you think about Grand Junction, Colorado, it's sort of a semi-rural area. There's not a whole lot of hospital competition, and they just have really, really high prices. And part of what happens is there's sort of a constraint on how much quantities can vary. It's sort of constrained by the just nature of the practice of medicine. Right? Some places are going to differ in how aggressive they are and the quality of services they offer and what they do, but it's going to be sort of within a pretty narrow Overton window. Whereas what I'll show you is pretty staggering variation in hospital prices that really reflect these sort of bargaining outcomes. And so you get this sort of huge spread in spending, half of it quantity, half in price, but price plays this sort of very dominant role because you get some very, very high extremes on the price side. Okay, let's just sort of anchor a little bit on prices. So when I talk about prices from here on out, I'm going to refer to the prices that hospitals negotiate with insurance companies, and we can certainly talk about physician prices in the follow-up. What I've done here is I've got a graph from our Price Ain't Right paper in, I think it was like 2019 in the Quarterly Journal of Economics. And it's going to sort of give you a sense of what the three main prices here look like. We've got hospital charges, right? These are not competitively determined. They're set by the firms, the hospitals themselves. These are going to be roughly double what private insurers pay, right? Those are these negotiated prices, and that's going to be broadly double what Medicare is going to reimburse. And this is one of the, I think, many ways that the US healthcare system differs from health systems in other countries. We're by and large the only nation that doesn't have some form of regulated provider payments. Right now, I'm an economist. I think markets work. One of the key themes out of some of my recent work is actually that markets in healthcare actually don't work too badly. The question that we have to ask, and I think this is where I'll end, is where can they work? Both in terms of quarters of the healthcare system and quarters of the country. And I think that's the sort of challenge we need to wrestle with. So I want to zoom in a little bit on how these negotiated prices get set and think about a model that really is, most of the work here has been done by Kate Ho, who's a wonderful economist at Princeton. Some work by my co-author Margaret Gaynor and a number of others who've sort of characterized the setting of hospital prices in sort of a 5-stage model. And it's worth sort of just internalizing a little bit what happens. So the first is hospitals are going to say, look, and these are sort of all kind of happening at once, but we sort of think of them in 5 stages. The hospital's going to take a look around and they're going to say, look, based on who's in my area, what I expect to have happen, what my costs are, I'm going to make a determination about my costs and the quality of the services that I produce. And there's some pretty good work showing, for example, that in areas with more private payers, right, and this will get into a little bit of I suspect, what Jeff talked about, in areas with more private payers where the expected revenue is higher, they invest in more sort of quality, cost-intensive services. If you look at a place like Montefiore Medical Center in the Bronx, where they're mostly seeing Medicaid patients, They're just making a very, very different set of investment decisions. So hospitals are going to sort of take a look at the landscape. They're going to decide what their cost structure is going to look like. And the reason I think this is so critically important to remember is costs aren't preordained, right? They're not sort of, you're not forced into making particular investment decisions. I like to pick on Yale, right? You can pick on your friends, right? Yale in one of our hospitals has a self-playing Steinway piano. I don't know if it's Steinway, so I shouldn't exaggerate. We have a self-playing piano in the lobby. I think it's a Steinway, whatever it is. It didn't have to be there, right? That's a decision they've made in sort of looking around at the landscape and saying, look, that's what our sort of customers want, right? They also have incredibly sophisticated operating theaters and other sort of clinical investments that they've made. But those aren't sort of things that you have to do. Those are choices. So second, after the hospitals have made a decision about cost and in return quality, they're going to negotiate with insurers over their reimbursements and their network participation, right? And basically this is a price volume trade-off game where, particularly for hospital care, if you don't join a network, you're not going to see that many patients. And so you offer a price concession for the insurance company to send patients your way by being in network. The insurer in this is going to think about how important that hospital is to have. And I'm going to sort of distill this down to two dimensions that they want to think about. One is there an alternative, right? So some aspect of like, what happens if I don't have that person, just simply in terms of what care patients can access. The other is in terms of just sort of how prestigious or how high quality those services are. So let's take the former. Again, pick on your friends. I could pick on my friends in Vermont, but this seems like not the forum. I'll make more friends picking on Yale New Haven. We've bought up all of our competitors, right? There's just not another hospital for me within probably 45 minutes. It isn't a Yale New Haven facility. And so if an insurer comes to that negotiation, their decision is basically like sell insurance. If I want to sell insurance, I have to negotiate with Yale. Otherwise, there's just literally nowhere for policyholders to get care. And I want to juxtapose that negotiation with, say, the negotiation that happens. I'm actually going up to Boston tonight. So in Boston, where there is a big dominant healthcare system, but there are multiple health systems. And so there, part of the reason that a high prestige system like Mass General can often command higher rates is because of whether real or perceived quality. Right? It isn't just that you can't sell an insurance product in Boston without partners. It's that you sort of, the customer base there maybe doesn't want the plan because they want to go to this high quality place, not because in the absence of it, they can't get healthcare. Right, so that's our second stage. Insurers are then going to take all that information into account. They're going to sell an insurance, they're going to set their premiums, they're going to sell their products. Patients are going to think about what healthcare they're going to need, right? If you're someone who's super healthy, maybe you don't buy the super generous high actuarial value plan that includes the flagship academics medical center. If you're very sick, maybe that's something that looks good to you. And then the sort of final stage is we buy insurance, I get a health shock, and I then have to think about where to get care. Do I go in and out or out of network? Where do I go as a function of my cost sharing? And that's going to then sort of loop around and influence my pricing. And so the question in the back of our minds, I think, as we think about what to do about hospital pricing is, can a market work? And one of the things that I've shown in my work is that hospital prices vary a lot. So this is more or less every hospital in the US ranked lowest to highest by their price for knee replacements. And that's going to be in red. So the height of the bar is going to be the price of the facility's knee replacements. The blue is actually Medicare. That's their regulated reimbursement rate. So I think a couple things should jump out at you. First, Medicare pays not, half, it basically pays half as much or less than half as much in certain instances as the privately insured. Second, boy, do prices vary a lot, from sort of $10,000 up to sort of 40 to 50. And third, Medicare rates are really not correlated with private reimbursements. And this is actually a pretty important point. What Medicare is trying to do is, as best as they can, approximate hospitals' costs. So I don't know that they say it officially, but basically Medicare wants to sort of say, we're going to reimburse hospitals costs plus a couple percent. And so I often sort of say this is like couple $100 million effort to try to back out hospitals' costs. And so sort of costs aren't really that correlated, at least as Medicare construes them, with true transaction prices. So prices vary nationally, right? So this is across the country. If we look in specific hospital referral regions, I've just put Denver up. I can't actually show Vermont because I have a minimum cell size, and you guys don't have enough hospitals for me to do it, which I'll come back to later, which would tell us a little bit about the scope for competition. But in Denver, right, the prices of hospitals vary by about a factor of 3 to 4, right? So lots of prices there. What's amazing is actually that even for things like lower limb MRI scans, so this is a single hospital and it's showing an identical service. The prices here vary a lot within a hospital across insurance companies. And this is, I think, another sort of fact that's leading us to think that bargaining leverage matters, right? Why do two insurance companies have different prices at the same hospital? Well, in a sense, because one insurer's just got a bigger market share, and so they're able to negotiate more aggressively with a hospital. So one of the sort of central themes in my work has been, okay, well, why is this hospital here on the right high priced, right? And what explains this variation? And if we basically just decompose out the correlates of hospital prices and think about what explains the largest share of the variance, the largest share is explained by the market structure of the hospitals themselves, or the degree of competition or concentration, more accurately, that those hospitals face. So in the cross section, a monopoly hospital basically has 15% higher prices than a hospital that faces a quadropoly market. Now, this isn't the effect of mergers. This isn't a sort of causal estimate of what happens when things change. It's just sort of saying in the cross section, if you're the only show in town, you get higher prices and markedly higher prices. And this explains, of all the factors, the largest share of the variation. But what's striking is it actually doesn't explain that much of the variation. There's a lot of variation in hospital prices that exist beyond market structure. And so it's just an example. And I think this is based on a paper that I did with Joe Doyle and John Gruber that came out a couple months ago that actually has fundamentally changed the way I think about health spending and hospital pricing in the US. So I'm gonna go, another 15 minutes or so. So market concentration, it's called a Herfindahl-Hirschman index. That's a measure of concentration. And all it basically measures is like the number of sort of competitors. And you want to sort of think of a Herfindahl-Hirschman index of 2,500 as sort of 4 equally sized hospitals. 10,000 is a monopoly. 0 is a sort of hypothetically perfectly competitive market. The Department of Justice and the Federal Trade Commission say, look, the sort of alarm bells should start sort of chiming when an HHI is above 2,500. The average market in the US is about 4,000 for the hospital sector, which is in and of itself worrying, but we're going to use that as a cutoff here. And I'm going to show you the variation in prices for places where the HHI of the hospitals is below 4,000, so below average, and above 4,000. So first, this just surprised me, right? There's no fancy economics here, but there's a lot of variation on both sides of that. Now you sort of see what I showed you in the graphs, which is like places with higher HHIs do have higher prices. But boy, there's a lot of variation. And so the paper that I did with John and Joe and John Graves, who's also a co-author, was trying to think of this question about whether or not markets can function by thinking about whether or not high-priced hospitals get deliver higher quality care. And it sort of seems like kind of an obvious question, but it's sort of this, I think, first order question about whether or not a market functions. It also turns out econometrically, it's really, really hard to measure because it turns out sicker patients go to higher priced hospitals, right? So my dad lived in Bennington. I mean, truthfully, at the end, we did not move him much because he had Alzheimer's, but when he was needing some cardiovascular intervention, I was willing to travel with him and take him somewhere to get intervention, right? And so if you sort of looked at him he went to a high-priced hospital precisely because he was really sick, he was also more likely to not do well because he was really sick. And so we got to sort of break this relationship to get this econometrically. What we do is we exploit, it turns out that ambulance companies have really strong preferences for where they take their patients. And so you can take the same patient in the two patients in the same zip code, different ambulances pick them up in an emergency and just have much different preferences and different probabilities about where they end up. And we can sort of use that sort of ambulance assignment to get the causal effect of going to a high-priced hospital. What do we see? Okay, well, it turns out we see very different patterns depending on whether or not a hospital faces competition. So if a hospital doesn't face competition and taken to a high-priced hospital, you just spend a whole lot more. Right, so going to a concentrated high-priced hospital is going to raise your spending by about 50%. And what is a high-priced hospital? It's basically a hospital in the 80th percentile of prices relative to one in the 20th. If you go to a hospital in a competitive market, a high-priced hospital that's, so again, 80th percentile, it's going to raise your spending a lot, again, about the same amount. But what's striking is it's going to dramatically lower your mortality. So it's going to lower your risk of dying by about 50%. Right, and that is going to turn out to be, which shocked me as somebody who's always critical of hospital prices, pretty surprising. It's actually cost effective. And I sort of take this as evidence that, okay, hospital competition can work, right? You can get prices that are correlated with quality if, and this if is doing a lot of work, if that market faces competition. Right, so it gets back to this question about whether or not a region supports and can support competition. So, the next question we should be asking about is whether or not, hey, Fiona, I'm on a call. Whether or not hospital prices are high because of cost shifting, right? And so, let's just sort of flesh out the theory. There's, I think, two versions of this. One is a sort of cross-sectional story, and one is a dynamic story. So the cross-sectional story is like, look, we lose money on public patients. We have high private prices that cross-subsidize. I think that's right. Right? I have no doubt that the margins are better on privately insured patients than they are on publicly insured patients. And so you can sort of cover your costs in some ways using the money you get from the privately insured. Where I strongly disagree is the idea that this is somehow dynamic, right? That is, if Medicare raised their reimbursement rates or Medicaid raised their reimbursement rates, that private insurers would actually lower, or the hospitals would lower their prices to the privately insured. And this is what really sort of intersects with Jeff's work. So the sort of first theory about what's happening is, basically, well, let's actually take the second. Hospitals have no choice about their costs. Medicare lowers their reimbursement rates. Hospitals sort of respond by raising their private reimbursement rates. It makes them look like they're high priced. The other story, and it's back to that sort of 5-stage model, is hospitals look out and they say, gosh, I have a lot of privately insured patients, right? I'm the Cleveland Clinic, I'm Mayo. I actually get patients from the Middle East who fly to see me because I'm so good. And they set a cost structure in response to those patients, which then, and in turn, makes them actually lose money on publicly insured patients. I think that's probably much, much closer to the reality of what happens. Right, and I think the idea that I sort of think about at Yale is we're a monopoly hospital. Our costs, we I think make pretty high profits. And there's some pause, I don't think this happens out loud, where we say, look, like making, let's say, 20% profits for a nonprofit academic medical center is unseemly. And so we come up with a new cancer center. And we call that a cost. And then the next year, we say, well, wait a second, we are now losing money on Medicaid patients because we have this cancer center. It was the decision to build in those costs that led them to lose money. right? And so it's really this question about whether or not costs are endogenous or exogenous. And I think the sort of prevailing view among academic economists and policy experts is very much of this sort of Jeff Stensland variety, which is absolutely, you see higher margins on privately insured patients, and that can be used to cross-subsidize. But that's not a function of something that's like a force majeure or a fait accompli. It's in a sense because hospitals get a choice about the cost structure that they face. What's the sort of evidence of this? I think there's a series of papers that show this pretty clearly. The first is that regions that have higher Medicare reimbursements actually have higher private prices, right? So it isn't that regions with lower Medicare reimbursements have lower prices. Second, when you see Medicare raise their reimbursements to providers, some work by Jeff Clemens and Josh Gottlieb showed pretty convincingly, and I see some of this in my work, private insurers respond by raising their prices. Or excuse me, hospitals respond by raising their prices. So when Medicare pays a hospital more, the next year the hospital actually charges more for care to the privately insured. So now we get into this challenge about growth in spending. Growth is more important and more complicated than cross-sectional variation. It's why every country, including those that don't spend as much on us, are really worried about healthcare spending, even though they spend less than the US. So what we've got here is we've got growth in inflation, workers' wages, health spending, and out-of-pocket costs. And what you basically see is that health spending is going up a whole lot more quickly than inflation or workers' wages. Right? Workers' wages have basically grown with inflation for the last decade or so. Healthcare costs have grown much more quickly. What does this mean? Even though your pay is going up, it feels like you're making less. Right? And the reason it feels like you're making less is because the money that you could have been spending on food and housing and your kids in an increasingly high share is going towards healthcare. I have work that's sort of in process that I think suggests pretty consistently with some other work and theory that you actually see that part of the reason workers' wages aren't going up as quickly is because of health spending going up, right? That is in the presence of employer-sponsored insurance. The money that would have gone to workers in the form of wages is going to them in the cost of healthcare. So why is health spending going up? So in the short run, so this is work by the Healthcare Cost Institute, I think we see pretty clearly in the hospital side that utilization is basically not changing, but prices are growing a lot, right? That is, it's hospital prices that are in the short run driving the growth we see in health spending. I talk a lot about hospitals, so why am I focusing on hospitals? It's kind of like when you ask the bank robber why they rob banks and they say that's where the money is. Similar story in healthcare, right? It's just the largest chunk of health spending. And so, we can talk about these other sectors. I tend to focus on hospitals because that's just the biggest chunk of the pie. This is the graph that I think we should all have in the back of our minds. That's tremendously important and shows again why we really want to think about health spending, hospital prices and why it's driving health spending growth. So this is work from the Bureau of Labor Statistics. It's looking at the price growth by industry. And hospital prices have grown faster in the 2000s than prices in any other sector of the US economy. Now we have a glass house situation, right? College tuition is the second highest bucket. So I am not blameless on this, but hospital prices are the highest growing sector. This also tells us why we should care about this for health spending, right? So hospitals are the biggest chunk. Their prices are going up more than prescription drugs and more than physician services. So it started at a high base, it's going up even more. It's what's driving growth in health spending. Why is this happening? Some of this is costs, right? Take COVID as an example, right? The shift to having to look at staffing agencies raise costs for hospitals, that's going to raise prices. Part of this is clinical improvements, right? So think about joint replacements that are happening in 2022 or 2023 versus the ones that happened in 2000s. Now the surgeons are wearing spacesuits and they're more likely than not going to be in a positive pressure room, right? That's going to show up on the cost side that's going to raise prices. The other is market concentration. There's been a pretty profound increase in hospital market concentration in the 2000s. So there have been about 50 to 150 mergers among hospitals each year. Now, if you look at the sort of degree of market concentration in the US, it's sort of, it's gone up, but it hasn't gone up that dramatically. So I don't think this is the only story. Right now, there's really good evidence that I've done, others have done, that shows that mergers of close substitutes does raise prices. And so I think we got to be very, very cautious of this. And then once you have market power, the die is cast. The other is just, I think in terms of why there are so many mergers, this is a graph I have for a paper that we're going to put out in a little bit. It shows there were about 1,000 hospital mergers between 2002 and 2017. The Federal Trade Commission, which is the agency tasked with enforcement in this sector, took 11 enforcement actions. And so it's just, they're incredibly underfunded. We do a lot of work showing that a lot of these mergers you could have known would be problematic, and the FTC is just not resourced well enough. And there's work that I've done that shows that the mergers you could have predicted were bad are going to raise prices by 10, 15%. So where does this leave us? And this is where I really want to sort of kick off a conversation. So what do we do? We started by saying health spending is high, it's going up, it's putting enormous pressure on families. Part of the reason that's happening is provider prices. I think there's sort of two questions we need to sort of think about that then influence where we go. The first, and this looks different in Vermont than it does in Boston or New York or New Haven, which is whether or not regions have the scale that's necessary to support all the services we want to see provided. So there's an excellent paper that came out last week by Josh Gottlieb and co-authors that I think uses a lot of really powerful econometrics to get to a point that I think we all probably reflexively feel, which is scale really matters for quality, and particularly for specialized care. And so they're basically showing that in what is in a sense cities, you get much, much better outcomes for highly specialized services. And that it turns out a large chunk, basically a fifth of Medicare beneficiaries, and it actually goes up a lot for even more specialized care, are actually traveling to cities for the sort of more specialized services we see. I think there needs to be conversations about, as a result of that evidence, what care we want to see locally and what care we're willing to travel for. In that sort of traveling more bucket, and I'll cite Josh's work, a lot of people are willing to travel. One of the things that's incredibly important is that the more affluent you are, the more able and willing you are to travel. And so I think there's a lot of scope, and I'll get into this, for a need for people traveling longer distances. But I think we've got to be very, very conscious that that's not the experience of that, and the ability to do that differs. And so it's got to be something that we really support. So that's the sort of first question. The second is whether or not regions can support competition. I'm a believer in markets. I think I'm a believer of markets in the hospital sector. I think competition has the power to offer a lot of virtues, where competition can exist. And so I think what different parts of the country have to do is take a look at the market as we see it today and say, can it support market determined prices? And I think there are just a lot of parts of the country, it's a minority, of the population, but a large chunk of the physical footprint of the US where competition just isn't geographically feasible, where hospitals don't face meaningful competition. That's not because they're doing anything wrong. That's because there just aren't that many people per square mile to support more than one hospital. And just like you can't have a monopoly bread company selling bread, you can't have a monopoly hospital setting prices for its services. So, then where do we go? So in a sense, there's two directions. One is a sort of market-based strategy that would have, in a sense, three components. One would be more antitrust enforcement. One would be potentially rolling back consummated deals and, sort of so-called, as some people refer to it, unscrambling eggs, and then making sure you block deals that are going to lessen competition going forwards. I think there's a big chunk of the US where we should be pursuing this. I think there's very real questions, and I'm happy to offer you my opinion if you solicit it, but I think there are real questions about whether this is the approach for Vermont. At the other extreme, and I think this isn't sort of inconsistent with economics, is saying, look, like there are some parts of the country where competition isn't feasible. So what should we do? And then asking what we should do. So, one, I think you can think about regulating prices. Here's the challenge I have with regulating prices. When we started, I said spending is a function of prices and quantities. And it turns out if you fix prices, evidence from Maryland suggests that providers can respond by just shifting their quantities. And spending in Maryland, where prices were regulated, grew just as fast as spending in every other place where prices weren't regulated. Such that Maryland moved, and instantly, like there are a bunch of folks who will talk about regulating providers' prices who will say, look, if you lowered their prices by 40%, like you'd save this much money. And they sort of ignore, what economists refer to as the general equilibrium effects, but basically they ignore everything else changing as a result. So I'd be very cautious of anybody who comes in and gives you a number and says, look, like if we just regulate providers' prices at 40% of what we are now, we're going to save, X billion dollars. It just isn't, I don't think how that's going to work out, and it sort of ignores the really important subtleties of the issues. What Maryland has done, which I think is interesting, I don't think it's been well studied, frankly. It's something I'm starting to do now, and we need to get a better sense of, is basically setting budgets for hospitals and saying, look, here is your budget. We're going to set this collectively as a group for all the different payers together. And we're going to just all come together and try to have trajectories. Now, the hard part here are the politics of it, right? Both because there are winners and losers. And one of the things markets can do, which is something that nobody wants to do, is decide which firms grow and which firms don't grow, right? And it's worth sort of thinking about it in the context of an industry where we don't much care about openings and closures, which is the restaurant industry. Right? If you open a restaurant that isn't very good in New Haven, in the sort of medium term, it's not going to stay open. If you open a really good restaurant, it's either going to get hard to get a table or it's going to grow. Maybe it's going to open 2 sites. Same thing actually happens in the hospital sector in the long run. I think the hard part is hospital closures are complicated for a number of reasons. The first is we all, myself included, have emotional attachments to the hospitals in our area, right? The number of times I've been to Bennington Valley Regional Medical Center with my dad when he was in bad shape is too high to count, right? And so I have a particular set of emotions attached to it. For a lot of us, it's where our kids were born and parents passed away. It's hard because in the short run, in the long run, places that are expensive and inefficient aren't good for the economy. In the short run, they offer a lot of jobs. And we got to sort of think about that. And, it's not as simple as sort of saying, presto, place closes, nobody loses out. right? They're winners and losers. The upside of a market is it doesn't know people's names and it can't lobby. It just sort of does its thing. Once you move towards these non-market mechanisms, you're having to sort of choose winners and losers, and that's very, very challenging. The last is sort of thinking about how you integrate payers and providers. You know, I think particularly where there isn't competition, those two being a little more sort of unified starts to make a little more sense. I'm going to finish just by talking about patient travel. It's really clear that patients do better when they go longer distances for specialized care. It's also true that patients locally do better when their neighbors travel longer distances for care. And that's because it has the ability to also increase the competition that facilities face. So I'll just use the example of Yale New Haven. I'm going to drive to Boston tonight. When I get on the highway, on my way to it, there are actually going to be signs nearby for the Hospital for Special Surgery in New York that are located in Connecticut. What they're trying to do is basically get people from Connecticut to travel to New York. And what that does is it exposes Yale New Haven to competition that they otherwise wouldn't be facing. And there's a very, very strong literature. I actually think the most pernicious consequence of lack of competition or too much concentration or lack of competition is actually on the clinical quality side. Right? There's very, very good evidence out there that hospitals that face more competition have better outcomes. And so I think part of what you can get once patients start going longer distances is the incumbent either saying, look, I'm going to specialize in what I can only do, or I'm facing competition and this will let me improve. So with that, I'll turn it back and I'm happy to chat about any and everything. Nobody interrupted me. I don't know if that's good or bad, but you know, we'll take it for what it is.
I've been to quite a few talks by economists. We're not that raucous, right? We're just we're a little bit more polite and subdued. But it'd be fun sometime to do that with you. Thanks so much for coming in and going through things. You know, I think it's valuable for me to learn from your work and to recognize that coming from Dartmouth, and I've been teaching people to use the Atlas since 2010. Right? And in the early years of teaching people to use that, it was really things have changed a lot, because I would be trying to encourage them to see the usefulness of it in their own practice. Yeah. But more recently, since your work and a lot of it coming out as far back as 2015, I've had to talk about not overgeneralizing, right? That the findings, and it's possible to be a very low Medicare spending hospital and a very high commercially priced hospital. And we don't understand that if you look at just the Atlas. I also appreciate just hearing the amount of evidence that you're able to bring to help us understand that markets and leverage matter. And you introduced us to the HHI. I'm not going to try to say the H's, but I do know from my own reading that scale goes to 10,000. We have 14 hospitals in Vermont. 10 of them have a score of 10,000. Of the other 4, 1 is below 4,000. You're cut off. Right? And the FTC, we'd like them to start getting more aware of hospitals when they go over 2,500. So our lowest is like 3,900, and it's just 1. I liked the part when you talk about setting budgets and some of the non-market ways of regulating this, and the politics of it. It's tricky, right? Because a regulatory board in Maryland, for example, could set a hospital budget growth of 5%, but a monopolistic hospital could come in and say, we need 10. And what enforcement mechanisms does the board then have to say, no, you get 5? And what can happen, we see it across the country, if a regulatory body sets it at 5, the monopolistic hospital comes in at 10, they often get 9. Right? And so the regulatory pressure that could improve quality and contain costs really doesn't manifest from just setting the budget unless there's some type of enforcement. At least that's my reading of the literature and of from your work. So I want to thank you a lot for coming in. I'm going to turn it back over to Chair Foster to run the Q&A and the rest of the board to have comments and questions. But just thank you again. You're very kind to join us this afternoon.
Yeah, thank you, Professor Cooper. I think I really wanted to jump in and interrupt at moments, but I was so engaged that I couldn't do it because I was learning so much. I didn't want to interrupt because everything you said took me a minute to make sure I understood it. So it was really, I think, reflective of what a great presentation it was and how informative it was. Your students are lucky to have you, and we are too, so thank you. Are you, what's your timing? I have you down till 3 o'clock. Do you have a hard stop at 3, or what's your?
Yeah, I can go a little over. I have to, I'd say like 3:10. I gotta probably hit the road 3:15.
Great. Okay. So I'll open up to board members for their own questions and comments, and then we'll take comments and questions from the healthcare advocate. So board members, please go ahead.
And just while people are thinking of them, just a quick sort of response to Tom. I think what you're absolutely right about is, in a sense, you need some disciplining function on healthcare costs, right? It can either be competition or it can be a sort of regulatory intervention. What you can't do is just sort of have nothing, right? That's the really big challenge. And yeah, so it's just two sides of the coin, and you got to pick either one or the other to get there.
Tom, did you have additional questions or comments? Okay. Well, we can go to member Holmes and then Dave and then member Lunge.
Sounds great. Zach, thank you so much for coming. Excellent presentation. I was going to say the same thing that Owen did, which is your students are obviously very lucky to have you as a navigator on this very complicated world that you've become very expert in. I also just want to say I'm familiar with not all of your work, but some of your work, and always very thorough, thoughtful econometric analyses, clever instruments, and I just really appreciate how you're improving all of our understanding, and to the degree that you can improve our work here at the Green Mountain Care Board, all the better. And I'm wondering, we have a pretty small data team, pretty strong but small data team. And I'm wondering, how can our data team take some of the learnings from your work, in trying to assess the drivers of price and spending variation here in Vermont, recognizing the limits that we have in small sample size and the volatility that comes with that, but thinking about our own hospital, regulatory process, how do we measure efficiency better, and trying to, get at that balance that you were talking about between small hospitals trying to deliver a wide range of services in their communities at low volume that may compromise both cost and quality, but they're also the economic engines in their community, right? We know that issue, but how do we start to think about efficiency, about scale, and about measuring it in a way that improves our hospital budget process? And how do we use some of your analysis, that you've done on price variation, on spending variation, with the data limitations that we may have with small sample size?
Yeah, so all really good questions. It's great to see you. So first, I think I'm a fan of descriptive statistics. I think before you can sort of get into the more high-powered work, starting by just saying, look, here's what our prices are. And I think there are a variety of ways to get price indices that are pretty darn reliable now, that will give you a sort of good sense of what prices look like for things where quality really doesn't vary. And so I'd sort of start with, building price indices. I'd have prices for maybe a basket of procedures, a couple of sort of really non-differentiated things. So non-differentiated are things where quality doesn't really vary, so like MRI scans. And then maybe some baby deliveries, and then some others. So I'd have those. I'd plot them over time. I'd benchmark them to Medicare. I think Massachusetts has done a remarkable job with I'm blanking on what their group is called, but can sort of offer both comparators, but also some inspiration about what looks good. When I was on the analogous body to you in Connecticut, we looked a lot at what Massachusetts was doing. So I think that's the first thing that I would do. I think the Medicare cost reports aren't perfect, but they give some window into costs, and I think I would sort of just have those visualized to hand. I think the really hard thing to measure is quality, because patient selection is just such a big issue. Now, I think, I don't know what quite the density is in Vermont, but there are some, Peter Hall is an economist who's at Brown, who's sort of taken this ambulance work and used it to come up with quality scores. If you sort of wanted to get fancy, that's probably the direction I'd go. I'd want to sort of think a little bit about which areas you can do that for, but I think that's how you can start getting at it. So I think just that's the first step. And once you're sort of comfortable with being able to measure some sense of price, some broad sense of quality, then I think you can start getting into these conversations about productivity. The other is just thinking about where patients go. So I think what would be really, really interesting and incredibly useful for the state, and I was very, very surprised by it when I looked at the work that Josh Gottlieb did on travel, was just how often people are traveling. And so I actually think it'd be worth taking a peek at data from the state and say, where are patients actually going for high acuity services? How far are they willing to travel? Who is willing to do the traveling? Where in the economic distribution are they coming from? And I think given that in some ways travel is going to be inevitable in Vermont, I'd probably sort of spend a bunch of time looking at that, because I think it's both an area of opportunity and an area where there's potentially a lot of inequity that's happening. And if you saw it, it would sort of, I think, allow you to say, look, how can we say, we'll make this easier for some groups, and we'll be able to facilitate it. I think, again, you didn't ask the question, and but I'll say it, not every hospital in your 14 can do everything. And, I think it's probably easier for me to say that in some ways. And I think given that that's the case, at the end of the day, like, what got me to health economics was, in a sense, a desire to make people's lives at their most vulnerable better. And what that means, in part, is getting the best care we can get people. And in some cases, that'll be locally, both because people have, my father was dying in Bennington. We weren't taking him to Boston. We weren't going to take him to New York. There was a trade-off between potentially the high acuity services that might be on offer and just the convenience of dying in your home. But for others, you might be much more willing to do that, and might be at a stage where that's much more appropriate. Can we facilitate that and make that easier? And I think getting to that is going to be, partly incumbent on Vermont navigating the complex set of issues on the sort of healthcare policy landscape in a very different way than you would if we were having this discussion in New York. And it's saying, look, we're sort of all in this one together, right? We're not going to compete our way out of this. And what we got to think about is, in a state that's much less densely populated, how do we get the best for our residents, many of whom just are not going to be able to hop on 91 and the Mass Pike and get to Boston.
Hugely helpful. And, some of what we're trying to do, there's an Act 167 that was passed that's actually allowing us and has given us some funding to be able to look at some of these questions and address some of these issues and in a data-informed way. And so, your analysis helps us with some of that data, but we have to bring it local. And so some of what we need to do is get that data on a local level so we can have those conversations with communities about how do we ensure that community members, no matter what your economic background, your financial status is, that you're getting the access to the best care possible, lowest cost, highest quality. So that's, your equity concerns. I really appreciate that. I recognize, same as you, that who gets to travel to the highest quality, lowest cost care is, So I don't want to take up too much time, but let me just ask one more question. Can you speak to some of your work on the out-of-network billing by hospital physicians? I think that's really interesting, some of your work, and I think it's helpful just to hear a brief description of some of your main findings.
Sure. So I'm going to loop just one quick second back to something I want to raise, and then I'll certainly talk about out-of-network billing. So two things. So the first is what I think is really challenging and hard to sort of wrap our heads around is it turns out there's actually not terrible, it's pretty good evidence that when hospitals close, in certain instances, mortality actually goes down. Right, and that's because the hospitals that are closing aren't sort of randomly closing. It's the hospitals that were struggling to provide good quality services. And so when they shut, patient health actually gets better. The second is, I'm, you talk to my students a lot. As I've discovered, they stay the same age. I keep getting older, and they sort of now are reminding me of that.
I feel your pain, Zach. I feel your pain.
Indeed. And when I first started doing this, I think I was more bullish about saying this is right and this is wrong, and economic and explain things, and here's what we do. And I've gotten much more to the point where I'm sort of, I think, just going to echo what you said, which is that these are conversations. And they have to be conversations that people have really thoughtfully with big swatches of the public. Saying they're not simple, there are trade-offs. Most policy issues don't have clear yeses and clear nos and clear sort of, they're not this, I'm more comfortable with sort of econ verbiage. They're not all Pareto efficient. That is like, they're going to make some people worse and some people better. And we got to be able to just have that frank conversation. So surprise out-of-network billing. So this is just this, again, very idiosyncratic feature of the US healthcare system where hospitals and physicians independently negotiate network participation agreements with insurance companies. And so it's possible to go to an in-network hospital, let's say in an emergency, where you don't get to choose your doctor and get treated by an out-of-network physician. I have some work in the New England Journal of Medicine and then in the Journal of Political Economy that shows this is happening 22% of the time for emergency room patients, which is just striking. And we sort of back of the envelope that when that happened, the average bill patients were getting was about $700. And again, if we go back to this sort of average liquidity, one of the things I say to my Yale undergrads and to my master's students or to policy communities is, look, for most of the people who come to the seminars where I speak, a $700 bill is incredibly upsetting, but it's not going to be the difference between eating or not. But for a large chunk, a really, really large chunk, it is the difference between eating or not, or major household expenses. And so that this is happening 22% of the time is frankly shameful. We did find that most of that was concentrated in a minority of hospitals where this was not an accident. Often they were bringing in large for-profit staffing companies who made a sort of deal with the hospital that in exchange for waiving the subsidies that you traditionally have to pay staffing companies to be there, they'd allow them to be out of network. So, that's really the sort of source of the problem. There has been a lot of amazing action on this at a federal level. President Trump really got behind the No Surprises Act, as did a large number of Republicans and Democrats in the Senate. It became law in 2021. It had two prongs. One was that it protects basically patients from getting an out-of-network bill, so they're only going to pay in-network cost sharing if they see an out-of-network provider physician in an emergency. And then it sets up an arbitration process to settle disputes. A lot of the companies that were engaged in out-of-network billing were not, how should we say, delighted with this change. And so they've been suing the administration both administrations pretty consistently over it. I believe March 8th, a judge in the district court in Texas actually stayed the arbitration component of the law. And so right now patients are protected, but there's no mechanism for settling the disputes. That will actually affect patients. Well, it won't affect patients in Vermont, but it will affect physicians and insurers in Vermont. And I think it sort of speaks to the need to address this, well, both at a federal level, like we need to figure out what to do in response to the lawsuit. I think it also speaks to why states can still have a role in helping to eliminate the financial pain this can cause.
Great, thank you so much. Appreciate it.
Yeah.
Hey, Zach, Dave Merman. So I went into emergency medicine for pretty much the exact same reasons you went into health economics, which is pretty fun to consider, but trying to help people at some of their most vulnerable times have better outcomes, live better lives, and get the best care we can. So it's a fun it's a fun relation there. So it's nice to hear. I really appreciate your presentation, and I guess I have some thoughts, but I guess I just wanted to say I really appreciate your discussion regarding the complexity of trying to figure out what resources should be locally, and what can people travel for, and also the real socioeconomic impact, and really, you know, who has the financial means and time means to travel for healthcare. My experience in the emergency department, which is, you know, different than general healthcare, there's a different patient population that we see, but that would be profoundly impactful for a lot of people that I see to have to travel for specialized care. I think one of these, I'm just sort of thinking out loud, and sorry if I don't come up with a question till later, but I think one of the interesting things is that, you know, we don't have a lot of places in Vermont that do a lot of things. We have one place that does cardiac catheterization, one place that does inpatient dialysis, very few places that do intensive care. We do have places where you can get an appendectomy, get a knee replacement or a hip replacement more broadly, you know, inpatient care for, you know, for general medical illness, but not requiring super high level of care. So this does, but it does come up often, you know, in the sustainability work about what should be where, and what makes sense, and all of these things you're talking about, the economic impact of a hospital on a community as a large employer, the access of care issues. And I think it was you that mentioned this early on, that you know, when cost goes up, access goes down because it costs too much, and all of these things really, I think, resonate with a lot of the challenges that we have on the board of trying to figure out how to best regulate our hospitals here in Vermont to improve access, improve quality, you know, and try to keep our costs in control. And actually, I think Tom's comment there, thinking about the impact of market power on the regulator, is something I guess, you know, we think a lot about it in insurance negotiations, but I think it also does have an impact on the regulator because you know, we really want these institutions to thrive. So wow, I don't know if I have a specific question for you. But I do really think this challenges of transportation, you know, it's really hard for me to wrap my head around how you could really help move patients around when right now we struggle with transportation as it is. But anyways, yeah.
Yeah, I mean, so actually, I mean, I think these are incredibly important points. Start by saying, PhD is sort of Latin for a doctor who can't really help you. So like, trust me, you're getting a lot more phone calls at 2 a.m. than I'm getting. Nobody needs to wake me up for much. And so I think having providers involved is incredibly important. And I think the question of travel is one where we need to be willing to sort of be pretty creative. So certainly like emergency room care. I mean, the broad sort of distinction I draw is between things where something literally is going to, like, somebody's hands or whatever is going to physically enter my body versus things that don't. And, I think primary care, certainly seeing certain specialists, I think that can be local. Non-emergent things that start to get interventional, I think starts to be in that bucket of we probably want to start thinking about it. Now, I think some of this is our time horizon. And I say that for 2 reasons. The first is I actually think we're going to start in the not too distant future, seeing really big changes in surgeries such that the surgeon isn't necessarily going to have to be in the same place as the patient. And I think that I actually don't think that's that far away. And that's going to fundamentally change the sort of calculus on a lot of that. And again, say I were president of UVM, right? That would be an area where I'd be thinking a lot about sort of research priorities, because I think there's just sort of a lot of scope for that changing the nature of patient travel. I talk about the time horizon again to also reflect your point about the economic opportunities and the economic costs of a high-cost healthcare system. And it's why boards like yours are tremendously important. And it's important that the appointments of the members are not on the same appointment cycles as elected officials. And it's because sometimes certain people need to think in the short run, and certain people need to think in the long run. I remember vividly, my dad had Alzheimer's, and so I would come up every weekend to Bennington, and I'd come up Elm Street and take a road to Maine, and I'd drive past Bennington Regional Valley Medical Center, and it was the nicest piece of property in the town, the most well-maintained. It was the sort of anchor property in many ways for Bennington. And if it were not there, Bennington would look different. And that's certainly true in the short run. I think it's equally true in the long run that a health system that is high spending and inefficient slows economic growth. And I think too often the economists focus on the long term without acknowledging the sort of short-term pain to get there. But it doesn't mean that that's not, in the long run, sort of better for communities. And I think part of the sort of challenge we all face, because we're all in this one together, is just sort of how you manage that transition, and understand that different people will do better and worse during that, and that it's okay for people to say this isn't nice for me, because they're not wrong, but to sort of just understand that what might not look fantastic for a year or two isn't bad in the sort of 10-year time horizon. I'll speak about Connecticut because I'm just a little more willing to be very, very blunt. My state is getting choked to death by 2 hospital systems. We have 2 hospital systems in the state. We have some of the highest, as I showed you, premiums in the country. That makes it very, very hard to have companies come in and be able to afford to hire workers. And our firms are leaving our state. We're getting slowly bled to death by our healthcare costs. You can make of that what you will for Vermont. That's not good in the long run. Now, it is equally true that if Yale New Haven took a 10% haircut, there would be a spike in unemployment next year. But I think we owe it to ourselves in Connecticut as a state to say the long run interests of having economic vibrancy are such that we have to be willing to have serious conversations about how to mitigate the short-term losses that would take us to that place where we're going to do better in the future.
Great. I'm just mindful of the time, and Professor Cooper, I'm going to give the healthcare advocate a chance to comment or question, and then you can be dismissed after the healthcare advocate if you need to get going, and then I'll do public comment after, because I know I want to be respectful of your time. So, Eric, please go ahead.
Yeah. So having done the drive from New Haven to Boston a few times, I want you to get on the road, Professor Cooper. So if I could just talk before public comment, that would be great. But thank you so much for your presentation. It was wonderful.
Cool. I'm gonna literally, no, I think I should be fine. So I'm happy to take a couple more questions and then hit the road.
Eric, go ahead and you can ask any questions you have, and then we'll let Professor Cooper hit the road. Thank you.
So I was just, the idea, Professor Cooper, about looking at willingness to travel, and I think it's really interesting. I think from my end, and the board has some appropriated funds for this, is being like there are multiple causal factors about why a person travels or not. So like, for instance, like you could look at the work of Mei-Po Kwon and some other kind of quantitative or mixed methods geographers about how time and cost influences travel decisions. So for instance, my brother lives in Brookline. I have a free place to park and to sleep. That radically changes my willingness to travel for care versus someone else. And so I think as we're looking to be data driven, it's not just, say, an analysis of VCures and what patterns we're seeing, but trying to get behind that. And it might be interviews, some form of a structured or semi-structured interview, to understand why people do certain things. And then you abstract or retroduce out of those interviews the causal forces at play. And I think, in a lot of ways, with an N of 14, we're always left in this situation in Vermont where statistical models, for the love of God, even linear regression, fixed effects, let alone a more complicated model, fails, right? Because it's so small. And I've wasted countless hours trying to figure out a way to do it. I would love, and the board staff, me and Sarah have talked ad nauseum about our frustration, but I think the approach towards descriptive statistics and then qualitative methods is probably the best we're ever going to do to understand the relevant questions in Vermont. And that approach is data driven. People's experiences are data. Data driven is talking about the method and how you're analyzing it. That's what makes something valid. And just before you go, Professor Cooper, your talk about out-of-network care was actually one of the factors that influenced me in thinking about how we provide free care in this state. And that resulted eventually in Act 119, which did that. Unfortunately, the out-of-network provider piece of that, having to offer free care assistance, fell out for various reasons. But your work was, at least for me, was one of the major early ideas that kind of got me thinking about the need to address that issue. So thank you.
Well, and thanks for putting the work on it. A couple just quick reflections, and then I'll head out. It dovetails with the points that were just made, and I think Jessica made earlier in terms of what we would do. I look as a sort of scientist, I'd be curious about doing some experiments, where you'd sort of think about how you'd offer the chance in some ways randomly to different people to get care, and then see what effect that had, and that'll really sort of give you the answer. You actually don't need that many people to do it. In terms of traveling and it being hard and listening to people, I think you're absolutely right. And I think too often economists are pretty darn arrogant and don't talk to people and don't listen. And then, we'll sit in a room and say, why doesn't anybody do what we say? And it just turns out that the world's a whole lot more complex than the models we predict and write about. But the flip side to that is I think what we do know incredibly well, and I think we can state with confidence, is that rising healthcare costs are breaking the backs of a lot of folks nationwide and a lot of folks in Vermont. And it sort of gets back in many ways to where Tom started, which is like there's just a choice. You can have markets, you can have ration. I think the challenge in Vermont is if you don't have either, because I don't think you have competition, there's nothing that's going to constrain spending growth. And the residual claimant of that harm, it is not spread equally across the population. The residual claimants are often the most vulnerable. Those folks often have the least access to a board like this and least access to elected officials. And I think one of the things that's important for you guys to think about it, again, change my views of this. The industry in the US spends more on lobbying than any other industry is the healthcare industry. Right. And so I think there needs to be a voice for the folks who are really sort of feeling this burden day in and day out. So I'm grateful to get the chance to be here. If I can help in any way, please don't hesitate to reach out, and it's sort of extraordinary the work that y'all are doing. So thanks for letting me chat a little bit and hearing about the issues that you're navigating.
Thank you so much, Zach, for doing this for us. This was extremely enlightening. This was really, really informative. So, I'm sorry, Dave Merman has his hand up. Go ahead, Dave.
I just wanted to say two quick things. One is regarding the out-of-network emergency physicians, being an emergency physician in Vermont. And I know of no hospital or practice or group of emergency providers in Vermont that has that practice where they have out-of-network providers. I'm aware of these throughout the country. It's sort of it's a scar on my field where there's provider groups that intentionally select patients when they come to the department. Certain providers select certain patients that are out of network. So they have different providers that are in network for different patients. I know none of that existing in Vermont. If the healthcare advocate heard of any of that, we would like to know, and other regulatory bodies would. I just want to sort of make that clear to the public as well. And the other, just one little tidbit I wanted to say about travel is that my understanding is that from some data is that the number one reason to refuse admission to the hospital is for care of pets at home. And I will tell you that is my experience. The number one reason why someone who is very ill will not stay in the hospital. In Vermont, pets includes farm animals, but it's the care of animals. And so when we think about travel, people traveling to Boston for care from, Derby, I mean, there's just, who's going to take care of the pets? It seems silly in some ways, but they're so important to people, and it's so important to their existence and who they are and how they live their lives, that I just think that we have to have humility that there's a lot of reasons why people don't travel that we can't model. And I'm not saying that you're advocating for that at all, and I really appreciate your nuanced view on this, but I think just in that conversation of traveling for care, that there's more than socioeconomic factors that will lead people to making decisions that an economist may not call rational, but I think are that are really impactful. So I just want to add that little comment.
So first of all, I actually think you have pretty low incidence of surprise billing in Vermont. It turns out Texas, that's the place you really want to mind your P's and Q's if you go on vacation. But about the travel, I think, and one of the things I was just sort of thinking about as we talked is, first of all, it turns out usually high quality care, if you travel, is both better and cheaper. So often the sort of savings is there. And so I think a lot of companies are starting to do this. And, I think one of the ways you can sort of think about this and with the companies that I talk about is you actually offer pretty substantial cash payments to folks to travel, right? So you're going to save $5,000 in the price of the surgery. You transport the patient, you give them $1,000 subsidy. And part of the reason you give them that cash is because they're going to know a whole lot better than you about what they need to take care of, and whether it's, the alpaca or the cows or the the dog Rosie for me, how to do that. And so I think it's just figuring that out.
All right, Professor Cooper, thank you. Have a safe drive, and we appreciate this. See you later. Thank
Bye,
you.
everybody.
All right, thanks. And with that, I'll open it up to public comment. Mr. Ham Davis, how are you? Please go ahead.
Okay, thank you. I have several questions for Dr. Cooper, but I can turn them into brief comments. It's striking presentation. Here's the way it appeared to me. First of all, I don't think it affects Vermont at all, and the reason is that the hospitals of any kind don't have any power whatsoever to negotiate on their own with the private sector, with the private payer. The reason is that the Green Mountain Care Board decisions include not only what you can spend as a net patient revenue, it depends completely on what you're allowed by the Green Mountain Care Board to charge to in the commercial, so-called commercial ask. So it just doesn't mean anything here. You can say a hospital or anyone can say that they need X amount of dollars, okay, and the only place they can get it, since they can't get it from Medicare and Medicaid, they have to get it from they have to get it from the private sector. But you cannot not ask the private sector in Vermont for a nickel over what you're allowed by the Green Mountain Care Board, and that is going to be. Not only has that been important in the past, that's going to be absolutely critical in the future. Number two, I just a comment. I was struck by the Dr. Cooper's reference to Gawande's article, which I've read 20 times and make all my friends read, that about his judgment about Grand Junction, Colorado. Well, that may be in there, but the main comparison that he made in that article was not with Grand Junction, Colorado. It was with the Mayo Clinic. And in 1984, I spent a total of 3 years working with Jack Winberg, who invented the whole small area variations data and is the father of the Dartmouth Health Atlas. And I can tell you, in the late 1970s and 1980s, it wasn't just Medicare in there in the original formulation. It was all the care and all the payers, and the differences per capita were very, very, very great. And it's different now because it's the Dartmouth Atlas goes all over the place and it covers tried the whole the country. Wenberg himself worked both in the UK and in Norway, and I looked at this in a long television documentary in 1984, and these differences with the original formulation of the small area variations technique covered all the care, not simply all the payers, not just simply the government payers. Anyway, so I just think that the real question is in Vermont. I think all the conclusions about the high prices that can be forced by hospitals that have total market power, which they do almost everywhere, so if you folks have a future chance to ask. To talk to Dr. Cooper privately or whatever. Well, one of the things I would want to ask him is he familiar with any system in the United States where any hospital, dominant or otherwise, is completely blocked from using their market power to get more money? Thank you.
Thank you for your public comment. I see Member Walsh has his hand raised, so please go ahead, Member Walsh.
Yeah. Thank you. It's common when we have public comments to listen and appreciate them, and I very much appreciate public comments. But I feel compelled to respond to the most recent. I taught with Dr. Winberg for a number of years. I think he'd be very disappointed in me if I didn't speak. So Dr. Winberg's variation research started in Vermont in 1973. By 1980, it was entirely Medicare based. In regards to price regulation, the Green Mountain Care Board has approved hospital budgets. Since its inception, we've approved 99.9% of what has been asked for. We set growth rates. Hospitals ask for higher than the rate, and we approve nearly what they ask. It's impossible to say from data that healthcare in Vermont has been heavily regulated. They've gotten what they've asked for. Dartmouth's data about quality and prices applies to Medicare, does not apply to commercial. Vermont's hospitals, their growth and prices have not been heavily regulated. The data is all there.
Mr. Carpenter, Walter, please go ahead.
Thanks, Owen. Again, Tom Walsh said what I had on my mind, close to it. I do want to say that to add a little bit to what Tom said, I think the Care Board should have more powers than what it has now. I think, to me, who almost died from market-based healthcare 16 years ago, there is, all of this is an argument for single payer. Some form of it, not necessarily like the British National Health Service or the Canadian model. There are various models of single payer, but what Tom said about the hospitals, and I think he's right. And to go on further with the networking problem, I was real interested in his presentation about that because I suffered through that network problem for months. In fact, the networking problem was one of the difficulties I had and why I went from being yellow to the same color of charcoal or ash in a fire pit, and why a nurse was so shocked that I was still alive because of this constant, ridiculous out-of-network problem that patients don't understand and have to fight all the time. So I wish he was still on. I would have questioned him about that, but I'll be quiet.
Thank you. And we're quite a bit behind schedule, and I have an appointment this evening I need to prepare for and do. So, Mr. Davis, I see your hand is raised again, but please go ahead. But we'll need to move on here in a minute.
Well, I just wanted to say, I've got a cellar, literally, with 200 pounds of Vermont healthcare data with all the payers. Okay, that's all I have. I can show anybody that wants to see them.
Great, thank you for your comment. Why don't we take just a 2-minute break so folks can get some water, and then we'll turn to Mr. Barber. Thank you. Okay, I see everyone is back, and it looks like Mr. Barber's here, so we can proceed. Mike, please go ahead.
Great, thank you. Just try and share my slides. Can you see that all right, Mr. Chair?
Yes, it looks great. Thank you.
Okay, I will try and get through this pretty quickly given the time. I am here to speak with you about something much less interesting than the previous presentation. I'm here to talk with you about certificate of need monetary jurisdictional thresholds. So a CON monetary jurisdictional threshold is basically a dollar value where if a project goes over that dollar value, it requires a certificate of need. So for example, the statute says that a healthcare facility that isn't a hospital has to get a certificate of need to purchase a piece of diagnostic or therapeutic equipment if the cost of the equipment is greater than $1 million. Not all CON categories have these dollar amounts associated with them. For example, construction of an ambulatory surgery center requires a CON regardless of the amount of money involved. But there are a number of them with these dollar values. And under the statute, the board can adjust those dollar amounts provided that the adjustment does not exceed an amount calculated using the cumulative consumer price index rate of inflation. So just over a year ago, on March 30th, 2022, the board voted to increase each of the CON monetary jurisdictional thresholds by 12.8%, which we calculated to be the maximum allowable increase at the time. We implemented those adjustments through an administrative bulletin. The statute used to require that adjustments be made by rule, and I think that's probably part of the reason why they were not made. But the legislature repealed that requirement in 2018, so we can do this without a rule. So last year was the first time that the board exercised its authority to increase these thresholds. And we had to make a few decisions about how to do this. First, we had to decide, when do you start calculating inflation from? And we decided that we would start from July of 2018, which is when the legislature last reviewed these thresholds and made adjustments. And then second, we had to decide what rate of inflation to use. And we ended up using the broadest measure of inflation, the consumer price index for all urban consumers for all items, seasonally adjusted. There were a couple of reasons behind this, which I don't think I need to get into, but using CPI for all items resulted in the greatest possible adjustment. Growth in CPI for medical care, which was the other measure we were looking at, was 10.2% over the same time period. So I just wanted you to see what are these thresholds. So this slide and the next slide shows the CON categories with these monetary thresholds, as well as what it was in the statute and what it is now. So the crossed out dollars are what the statute says. The underlined dollars are what's in the CON bulletin that I mentioned with the revision. So as you can see here, there are thresholds that apply to hospitals and thresholds that apply to healthcare facilities other than hospitals. And the major categories are, first, construction, development, purchase, renovation, or other establishment of a healthcare facility or a capital expenditure by or on behalf of either a hospital or other healthcare facility. Second, the purchase or lease of diagnostic or therapeutic equipment. And then third, the offering of a new healthcare service or technology. in which case it's the annual operating expenses that are relevant. And then if a project is expected to be really costly, you need to secure what's called a conceptual certificate of need in order to spend money on planning activities like architectural or design services, and there are dollar thresholds associated with those. So for both hospitals and non-hospitals, it was 30 million, now it's 33.7 million. And then finally, we don't see this much, but there is an kind of exclusion. You're allowed to spend a certain amount of money in preparation for obtaining a conceptual CON. And so that's the final row on this slide. So it's been a year. I wanted to bring this to you to see if you want to make revisions again. So this slide is showing you on the left-hand column the CON category. The base column is the dollar amounts that are in the statute. The current column is what the thresholds currently are. CPI-U all items column is showing what those base amounts could be revised to now. So the growth in CPI-U all items between July 2018 and February 2023 is just over 20%. And then I wanted to show you on the right-hand column what the growth in CPI-U medical care has been. So just a little bit over 13%. I also thought it would be helpful to see how Vermont stacks up to other states in terms of its monetary thresholds. There's not, unfortunately, a kind of up-to-date survey for the states with CON programs that has this information in it. There was at one point, but it's pretty dated now. But I did take a look at our neighboring states to see where they are. And as you can imagine, other states' categories don't match exactly with Vermont, so it's a little difficult to compare them like this, but I tried as best I could. And so that's what the next 3 slides are. So this is Maine. Maine updates its thresholds, or at least most of its thresholds, by CPI medical care. It does not update this new healthcare facility category. Moving on, Rhode Island. This is showing Rhode Island's thresholds. It updates, as best I can tell, its categories by CPI all items, and then Massachusetts has a kind of complicated setup. I hope I captured it right, but am certain that they update their thresholds, or at least the dollar values here by an index that's not CPI. It's Marshall and Swift index. And then I also put together some slides just to give you a sense of what are the CON projects that we've reviewed since 2018, what were the dollar values, how did they come under our jurisdiction, so you could get a sense of how they relate to the thresholds as they currently stand, and potential revisions. So that's the remainder of the slides. I don't think I need to go over it in detail given the time, but I guess I would say that I didn't see a ton of concern that by increasing the thresholds we would be excluding a bunch of stuff. There were a couple things that I noted in red where in red text that, so for example, this is looking at the hospital capital expenditure threshold. It's $3.37 million currently, could be revised as high as $3.6 million. In 2023, we reviewed UVMMC's project to relocate its dermatology and ophthalmology practices. Because of the dollar value, that required a conceptual certificate of need. If it was increased, if the conceptual CON threshold was increased to 36 million, that wouldn't have triggered that need. So I tried to note things like that, things that were on the line with red text. And one thing that became clear in doing that was that some of these some of these equipment replacements trip both the equipment threshold and the capital expenditure threshold. So if we increase the capital expenditure threshold, it, potentially might exclude some of these from that category, but, I think they would still be reviewed. They would still trip the equipment threshold, if that makes sense. So, sorry I sped through that, but I'd be happy to answer questions. Really, we didn't notice a vote for today, so I wasn't looking for a vote, but I can come back at a later time and get your vote if that's what you want to do. I really just wanted to, like I said, it's been a year, bring this back to your attention and see if there's any interest in revising these again.
Thank you very much, Mr. Barber, and I really appreciated the context you gave us with looking at what the other states have for their thresholds. I appreciate that. This is really great. This has made it really simple to assess. I have no questions. I'll turn it, and I'd be ready to vote, next week or at some point soon, but I'll turn it to my colleagues to go ahead with any questions or comments they have.
That's one quick question is it possible to have this automatically adjusted as opposed to having to vote each year to adjust up these thresholds based upon CPIU?
Yes, that would be possible.
Might be something to consider, but I support those.
I support it also. I support automating it if it's possible. I also think it ties in really nicely with the presentation we had from Professor Cooper, because decreasing barriers to entry can be helpful for competition, right? The certificate of need process originally was meant to protect patients and control costs, but the evidence from across the country is that the process of going through certificate of need has gotten very expensive, while the outcome hasn't improved quality very much or reduced costs. So rethinking how we think about certificate of need seems smart. Maintaining some certificate of need also seems smart because it's the only state tool that allows some control over it's an important tool for states to constrain dominant healthcare systems. As Dr. Cooper talked about, we need some ways of constraint. So I think it just flows really nicely, and it's an important topic. So thank you for talking with us.
Okay, unless there's any other board comments or questions, I will turn it to the healthcare advocate for any of their comments, if any.
No comment, Chair.
Great, thank you. And I'll open up to public comment. All right, Mr. Barber, thank you very much for this, and I'm sure we'll take this up pretty soon, so thank you.
Okay, thank you.
That's all we have on the agenda. Is there any old business to come before the board? New business? And is there a motion to adjourn?
So moved.
Second.
All those in favor, please say aye.
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 Aye. Motion carries and the meeting is adjourned. Thank you, everyone, and have a nice evening.